Today's topic is Internal Medicine 17.3 Classifying Migraine. Describe the distinguishing features between classical migraine and the so-called non-classical migraine. Migraine is a leading cause of disability in those below 50 years. It affects women more than men. It impairs the quality of life and productivity. So at the end of this session, the learner should be able to describe migraine as a primary headache disorder, classify migraine according to standard clinical categories, differentiate migraine with aura from migraine without aura, previously called classical migraine and non-classical migraine. So the skills required are identify migraine subtypes from a clinical case, distinguish migraine from tension type headache using key features. And you should be able to recognize migraine as a neurological disorder, not merely as a psychological complaint. That is the attitude you should learn. So we go to the definition. As per Harrison, migraine is a recurrent headache which lasts 4 to 72 hours. It is unilateral, pulsatile. These two features are very important. The word migraine came from migrainea, that means hemicranial. It is unilateral. Second, the characteristic feature is pulsating, usually associated with nausea, photophobia, phonophobia. So the duration is important, 4 to 72 hours. And the characteristic feature, the pulsating feature. And again, remember that migraine is a complex neurovascular disorder due to brainstem activation through the trigeminovascular pathway. So this you should remember, the trigeminovascular activation. So the classification of migraine as per the international classification ICHD principles we will be discussing. First, as migraine without aura. This was previously called a common migraine or a non-classical migraine. Second is migraine with aura. This is the previous term, or this is classical migraine. Then there is chronic migraine. When there is a neurological deficit like hemiplegia occurs, it is called hemiplegic migraine. There is another type, the basilar type migraine, retinal migraine, and status migrainosus. So these are the terms that you should remember. Migraine without aura is the most common form of migraine. It accounts for approximately 70 to 80% of the cases. So a common migraine or migraine without aura is constitute the majority, 70 to 80%. Migraine with aura is previously called classical migraine, and the key feature is presence of aura. So what is an aura? Aura is a transient focal neurological symptom that precedes headache. And the most common aura is visual and is classically described as the scintillating scotoma or fortification spectrum. So visual aura is the classical, but you can get other types. So for it is a transient neurological symptom and it should precede the headache. So this is something called the scintillating scotoma. So at 0 minute it starts like this, it spreads like a sea-like and goes away. And the headache will occur usually within 60 minutes. That's another point to be remembered. It is a aura precedes headache. And what is the duration of the aura? Aura usually lasts 5 to 60 minutes. Headache follows aura within 60 minutes. It is often, as mentioned, unilateral, throbbing or pulsatile. There can be nausea, vomiting, photophobia, and phonophobia. The aura is believed to reflect cortical spreading depression. I will come to this in detail later. As mentioned, it is a visual, there is some depression occurring in the occipital cortex leads on to the visual symptoms. It can be sensory, rarely motor, and sometimes speech disturbance like dysphagia can also occur. So what is the pathophysiology of aura? Aura is due to cortical spreading depression. So in migraine without aura, previously called common migraine, the key feature there is no aura. Headache and other things are same. It is again unilateral, duration 4 to 72 hours, moderate to severe intensity, can be aggravated by routine physical activity and associated nausea, vomiting, photophobia, etc. So the only difference is the absence of aura. Migraine without aura is diagnosed clinically when characteristic headache features occur in the absence of neurological symptoms. So that is neurological symptom here means is the aura. So this table shows the difference between classical migraine and or the migraine with aura and migraine without aura. And the classical migraine is only less common. 70 to 80% is through migraine without aura. And again, the aura is due to the cortical spreading depression, and the headache is due to the trigeminovascular activation. Hope these points are clear. Other variants we have already mentioned. You can get a hemiplegia, that is called hemiplegic migraine, basilar type of migraine, and retinal migraine. This will be discussed in detail with case examples later. There is another term, the status migrainosus. Attack lasts more than 72 hours. Severe disability and may need urgent treatment. So usually the migraine lasts 4 hours to 72 hours. If it is lasting more than 72 hours, it is called status migrainosus. As mentioned, the pathophysiology of aura is a cortical spreading depression. There is a transient neuronal depolarization that spreads across the cortex. So it usually starts in the occipital cortex. Without looking into the or respecting the sulci or the gyri or the vascular territory, it spreads from the occipital core. That is there is a transient neuronal depolarization that is occurring. Migraine without aura, there is no focal neurological symptoms. Directly there is headache and is the most frequent type as I already mentioned. And headache features also described. It is unilaterally 4 to 72 hours, but again remember the unilateral doesn't mean that it always occurs on one side. It shifts from one side to the other side. If it is occurring only on one side, you have to think about some other underlying causes. Physical activity aggravates the symptoms, and usually it is associated with nausea, vomiting, and vomiting usually relieves, and many patients induce vomiting. There is photophobia and phonophobia associated. So the differences already have mentioned. In the classical one or the migraine with aura, there is aura, and in the other type there is no aura, but other symptoms are similar. The pathophysiology migraine is again remember is a brain disorder involving altered sensory processing and activation of the trigeminal afferents. Or you can say it is a trigeminovascular inflammation. So cortical spreading depression leads on to aura. And the trigeminal nerve activation or trigeminovascular activation and CGRP release. There is neurogenic inflammation, brainstem dysfunction that is occurring. So this is showing the cortical spreading depression which I have already mentioned. It starts in the occipital cortex and it spreads anteriorly without respecting the vascular or boundaries. This leads on the aura. If it affects the sensory cortex, you get a sensations as the aura. If it is a motor cortex, you get a motor symptoms. If the speech area is affected, you get a dysphagia or speech problems. So neurobiology, there is a trigeminal activation, release of CGRP. And thus the CGRP leads on to neurogenic inflammation, vasodilation, and is one of the targets for therapy. Then chronic migraine. The migraine lasts more than 15 days a month of more than 3 months duration. It is chronic migraine. Red flag symptoms. Thunderclap onset. Migraine is never abrupt in onset. It usually starts, there is some prodromal symptoms, it goes to a peak, pulsatility in nature, and then it subsides. If suddenly it occurs, thunderclap, age is more than 50. Migraine will not occur usually after the age of 40 or 50. So new onset headache occurring at the elderly or after the age of 50, always think it as a red flag. Either neurological deficits are added upon and is persisting, again it is a red flag. Or change in the character of the headache, all these are important. So always rule out sudden thunderclap headache, first headache after the age of 50, focal deficit persisting, papillary edema is present or other neurological deficits are present, and the patient has got fever. These are red flags. So take home message, migraine is a neurovascular brain disorder. Primarily there are two major forms, with aura and without aura. Aura is a reversible focal neurological symptom due to cortical spreading depression. Without aura, 70 to 80%, that's the majority, and the diagnosis is clinical. In the next session, we'll be discussing about the few case examples and describe management also. So in this session, we have mainly discussed about the various types of migraine. These are the usual questions that can be asked. Define migraine, what is scintillating scotoma, what is cortical spreading depression, differentiate migraine with and without aura, what is chronic migraine, what is a neurotransmitter that is implicated, here to say CGRP. So stay tuned for further videos. Thank you.